In this session, we are going to discuss about the non-organic dysfunctions related to the visual system. Non-organic dysfunctions relate to those situations in which symptoms and/or signs cannot be correlated with a definite organic underlying pathology. So the denominator of a non-organic dysfunction is absence of an underlying organic pathology, and there are three categories of entities under this umbrella. We have functional or conversion disorders, factitious or malingering situations, and somatic symptom disorder. In functional and factitious or malingering disorder, there is a mismatch between symptoms and signs of the suspected underlying disease. In somatic symptom disorders, however, the symptoms and signs of the suspected underlying disease match. In functional or conversion disorder, the patient is either impaired because of the symptoms or is distressed from the symptoms, and there is no need to prove that the symptoms that the patient is reporting are genuine. In a factitious or malingering situation, the patient feigns symptoms and does not appear to be either impaired or distressed because of the symptoms, and the patient does so to obtain the sick role for professional or social benefit, and then it is called a factitious disorder, or to obtain personal gain, in which situation it is called malingering. In somatic symptom disorder, where the symptoms and signs of the suspected underlying disease match but there is no underlying organic pathology, the patient has excessive thoughts and feelings about the underlying disease. The ophthalmologist's role is to avoid missing any underlying pathology, particularly those in which the symptoms are likely to be labeled as functional and the findings are liable to be missed, and these include early aberrations of media like early keratoconus and early posterior subcapsular cataract, subtle central serous retinopathy and epiretinal membrane, early stages of retinal dystrophies, subtle chorioretinopathies like white dot syndromes, and afferent pathway disorders. In a non-organic situation, often there is associated psychiatric disorder, and the ophthalmologist is expected to identify the possible coexistence of a psychiatric issue and make appropriate referrals for the benefit of the patient. The goals of examination in a patient suspected of having non-organic dysfunction is to exclude any possible underlying pathology, ophthalmic or neurological, by checking for all possible signs of the probable disease or disorder, and perform tests to match reported symptoms with signs elicited from these tests, such as visual acuity, visual fields, ocular motility, pupils and accommodation, and leads. For the purpose of this presentation, we will use this abbreviation NOS to refer to a subject who has no underlying organic pathology to explain his symptoms and signs. So in a bilateral no perception of light situation, to exclude or identify a patient with no underlying organic pathology to explain his symptoms and signs, we can do finger touching test, pupillary light reflex test, optokinetic nystagmus, mirror tilting test, or visual evoked potential. We know that with the help of the sense of proprioception, a blind person or a normal person with both eyes closed will be able to touch his both fingers when asked to do so, but an NOS may not demonstrate so. In a bilateral NPL situation, we expect the pupillary light reflex, either direct or indirect, to be absent. With bilateral NPL, there should not be any nystagmus with a rotating O'Kane drum, but an NOS complaining of bilateral NPL may show nystagmus with rotating O'Kane drum, and an NOS with bilateral NPL in mirror tilting test shows movement of the eyes. A normal VEP rules out organic lesion, but an abnormal VEP does not definitively indicate organic lesion. In a unilateral NLP situation, we can perform the tests which we have mentioned for a bilateral NLP situation unilaterally on the reported bad eye after covering the other eye. In addition, there are other tests for an unilateral NLP situation. We can check for relative afferent pupillary defect, which will be absent in a NOS reporting unilateral NLP, And we can also detect an NOS with unilateral NLP with the help of prisms. We can position a prism base out over the reported bad eye, and an NOS reporting unilateral NLP demonstrates movement of one or both eyes. And if a prism is positioned base down over the reported good eye with a projected single line, the NOS will perceive diplopia. In another prism-based test, in a situation of unilateral NLP, the reported bad eye is covered and a base-up prism is held before the good eye, so that its apex splits the pupil and the patient reports a diplopia with only the good eye. Now simultaneously, the bad eye which was covered is uncovered and the base-up prism over the good eye is shifted downwards. So both these two movements are done simultaneously, and NOS will report persistence of the diplopia, which should not have been there if the bad eye was actually having unilateral NLP. In a unilateral NLP situation, if we test stereopsis, the NOS reports image jumping out of the plate, and there are nomograms to match vision in the wart's eye with stereo acuity level with both the eyes. Confusion tests can also be done in a situation with unilateral NLP, and a prerequisite for confusion test is the patient not being able to detect which eye is actually being tested. Confusion tests can be done either by fogging or with a Duochrome chart. In fogging, a plus cylinder and a minus cylinder are placed parallel to each other in front of the good eye only, and when one of the lenses is rotated, an NOS does not report blurring of vision, which should have been so if the bad eye was actually unilateral NLP. In a duochrome test with a red-green glass and a duochrome chart, the patient reads the red half of the chart with the eye having the red glass and the green half of the chart with the eye having the green glass, and an NOS will be able to read both sides of the duochrome chart, which should not have been so if it was actually a situation with unilateral NLP. Duochrome test can also be done with Ishihara plate, and a non-NOS normal subject can identify Ishihara plates through the red glass but not through the green glass. So the red glass is placed in front of the reported bad eye and the green glass is placed in front of the other, and with such an arrangement the NOS will read the plates, which a patient with an unilateral NPL should not have been able to do. When the complaint is of a reduced visual acuity in one eye, identifying or excluding a non-organic situation is more difficult than in a situation in which the patient reports unilateral NLP, because here we have to prove a better visual acuity than the patient is reporting. To do so, a prism can be used and oriented base down over the reported good eye with an electronic chart projecting a single Nellen line, and the NOS will be able to see two lines with equal clarity, which a patient with an organically reduced visual acuity in one eye will not be able to see. Confusion tests can be used to determine visual acuity better than reported by the patient, and we can use the fogging test and the duochrome test as mentioned before. And when the complaint is of a reduced visual acuity in both the eyes, it is most difficult to identify or exclude a non-organic complaint. Bottom-up vision testing is a very important test in this situation, in which we start with the smallest line on the chart and project a single line at a time with an electronic chart, and progressively going to the next larger line. Each time the examiner tries to convince the patient that the letters are much larger, and NOS often shows much better VA than originally reported with single Nellen lines. And when tested with an alternate chart with a different optotype, the NOS may demonstrate a different visual acuity recording. For these situations, there are also specialty charts with the top line being smaller than 660 and with full correction being placed with multiple lenses. Removing or adding only a small cylinder or sphere can make an NOS report significant improvement or deterioration in vision. For a patient complaining of visual field defect, In contrast to kinetic perimetry, which we will be discussing in a subsequent slide, automated perimetry is not very useful to identify functional loss. However, if we get a consistent central scotoma on repeated testing, then we can fairly confidently rule out a functional visual field defect. And when the visual field is tested first monoocularly in either eye and then tested with both eyes open, an NOS often reports seeing the same visual field defect, which should not have been so if the visual field defect was due to an underlying organic lesion. Confrontation testing can be done by either a so-called motility testing or by a so-called silent field testing. A motility testing is done after preliminary examination of the patient is complete, and the examiner tells the patient that motility will be checked, but in fact he is checking the visual fields. And then saccade testing is done with an object, but the object is gradually and progressively positioned deeper into the areas of the defect. And in case of an NOS, believing that the motility is being tested, will continue demonstrating the saccades, which will not be so in case of an organic lesion when the object reaches deeper areas of the visual field defect. And in silent field testing, the examiner presents his hand in various positions of the visual field with or without displaying his fingers. That is, at times he displays the fingers and at times he doesn't, and the examiner asks the patient whether the fingers are being seen or not. Each time the hand is shown, but this he does only for the initial few presentations. Then the hand is presented without showing the fingers and without being asked in the reported area of the visual field defect. In case of an NOS, he or she will report that the fingers are not being seen even when he or she has not been asked. But if there is an underlying organic lesion, the patient will not respond when the hand is presented in the location of a real visual field defect. Kinetic perimetry characteristically shows constricting isopters spiraling inwards towards fixation when performed sequentially clockwise or anti-clockwise. So when the outer margin of the visual field defect is measured in each of the meridia, then it will be seen that the outer margin gradually shifts nearer and nearer to the fixation, and when this is repeated with a larger object, an NOS will report further constriction with the isopters overlapping the previous one. This should not have been so in case of a visual defect from an organic lesion. But if there are steps along the vertical and horizontal meridian, that does indicate a possibility of an organic lesion. Steps along the vertical meridian suggests a neuro-ophthalmic field defect, and steps along a horizontal meridian suggests a glaucomatous or an ischemic field defect. A tangent screen can also be used to identify an NOS subject complaining of a visual field defect. So the visual field is initially tested with the patient usually 1 meter from the tangent screen, and then again with the patient at 2 meters, that is double the distance from the initial testing, with the object now being used double the size of the object used in the first position. So with the subject in the first position, that is at 1 meter from the tangent screen, if this line represents the outer margin of the central preserved visual field, then when the distance of the subject from the tangent screen is doubled, in case of a patient with an underlying organic lesion causing the visual field defect, the line representing the outer margin of the central preserved visual field will actually double in size. But in case of an NOS, this doubling in size of that line will not occur, and it will either remain the same or will enlarge only marginally. Functional disorders of ocular movement include voluntary flutter, which has been discussed in the session on nystagmus and nystagmoid eye movements. Gaze palsy can also be a functional disorder, and it can be tested by vestibulo-ocular reflex testing, mirror testing, and inner ear caloric testing. These tests have been described in the session on supranuclear disorders of eye movement. Supranuclear disorders of eye movement, in contrast to infranuclear disorders of eye movement, may have similar results with these testing methods as functional disorders. Spasm of near reflex is also a functional disorder, and the patient with a spasm of near reflex will demonstrate full ductions when tested with resolution of the accompanying meiosis. Functional abnormalities of the pupil and accommodation include pharmacologic mydriasis, and this does not respond to pilocarpine. Functional near vision abnormalities can be either a spasm of accommodation or a paralysis of accommodation. In paralysis of accommodation, the patient reports that he or she is not able to see a near target. With a corrected normal distance vision, when plus lenses are used to attempt to correct near vision, an NOS will respond that he or she is still not being able to see at near. But this does not happen with an organic paralysis of accommodation. Spasm of accommodation is a part of spasm of near reflex, and if we test the refractive error before and after cycloplegia during the period of spasm, we can get a large difference in results of the refractive error of almost 8 to 10 diopters. In functional ptosis, an NOS will show lowering of the brow instead of brow elevation in case of an organic ptosis. And with intact eye movements, when the NOS is asked to look upwards, he or she will not do so in order to not elevate the lid. Orbicularis spasm can also be functional and is often relieved with pressure over the supraorbital notch. So the ophthalmologist should acknowledge functional symptoms with empathy, explain and reassure that there is no organic disease, appropriate referral for psychiatric consultation, and the ophthalmologist should follow up regularly as a patient diagnosed to have a functional disorder may later show evidence of underlying organic lesions. Thank you for listening.